All right, everyone, welcome back to another episode of Forward Physio. I am here with Beau, aka the Stress Fracture Physio or Beau Science, whatever you want to call him. I'll let Beau tell you sort of what he wants to go by. And we're here today to talk about stress fractures. Really quick before we get into it, if you are a longtime listener of the podcast, please consider leaving a review or sharing it with a friend or family member. It helps the podcast grow so that we can reach more and more people. And without further ado, I'll let Beau introduce himself to you guys.
So hey guys, obviously I'm Beau. I'm a physio out of Sydney. I've worked in a range of different sporting environments, primarily rugby, over the past few years, and I've been working at a clinic that is specifically for runners. Being that it's for runners, we get an absolute flood of stress fractures. We probably see as a clinic 10 to 15 stress fractures a week, which is massive, some of the most in Sydney for physios. And I've developed a keen interest in that area, diving into the research, probably read hundreds of papers on it at this point. A little bit obsessed, having had my own stress fracture as well. And based on some of the stuff I've been putting out and people I've spoken to, a lot of people have reached out and told me about their complex cases. I've had lots of patients referred by doctors and other physios of just wacky, weird cases that I didn't even know existed, even though I've read like about every different stress fracture out there. So it's been really interesting past couple of months and past years, just smashing out all of this.
Yeah, you're like the Batman of stress fractures. Like you went off, you disappeared for a little bit, and you came back as just this wizard in stress fractures with all these like new superheroes.
No, mate, I don't think that's how it is. There's not enough research out and people talking about stress fractures other than Rich Willie. So I just thought I'd jump in the space and give what I know, share what I know.
To me, the modesty is always a good sign of someone who knows their stuff. So what, how do we actually define a stress fracture? How is it different from, let's say, like a more traumatic fracture where you fall and you break a bone?
Yeah, so we're all aware of what a fracture is, like you said, just when you fall over and there's trauma. I think the main difference with a stress fracture is it's essentially an overuse injury of the bone. So when we do develop stress fractures, it's not the same presentation, it's not the same healing, and it's not the same mechanism that we get with a traumatic-based fracture. So because of all of those reasons, actually, stress fractures end up taking about twice as long to return to play, at least in a large study done by Aspetar on soccer players. In the research as well, we do see that it takes quite a long time to return to running and to return to sport after stress fractures, and that's for a number of reasons. Number one, the mechanism is different. When we have a traumatic fracture, the bone is going to break pretty much along a straight line, hopefully we don't have a comminuted fracture, but it's going to break along the weakest point, and that's going to mean there's not actually that much healing that needs to happen. In comparison, when we have a stress fracture, we're having repetitive loading that's causing micro damage, and it's accumulating very widespread, not just in one straight line, but across a large portion of the bone that's being stressed. And that means there's actually a lot more bone that needs to be absorbed, healed, and then built back to be stronger so that they can return to activity. So number one, that's a very, very simple explanation as to what a stress fracture is, basically an overuse injury. But the other things that go into stress fractures around recovery, around general health, are some of the other reasons that this takes a long time. We're not going to be able to just heal a fracture when someone's unhealthy or has other problems in the background that are going to take a while to address on their own. It's not just an accident that happens. There's lots of factors going on that generally bring about these stress fractures.
It's interesting. You would think that the stress fractures would be a smaller fracture. We tend to think of them as almost like hard to identify. And when someone breaks a bone, you're thinking of like this massive break, but you're saying that there's more bone healing that needs to occur in the case of a stress fracture in most cases.
Yeah, so if you look at like a normal fracture on an MRI or an image, it's actually going to be like pretty much just like a straight line, or like a cracked line that's quite thin. You look at a stress fracture, generally they're actually quite like thick. There's more basically remodeling that needs to go on. And when we have resorption of that as well, the cells that go in and eat the bone to clear it out, they actually eat up more than they need to because they have to remove everything, not just the crack. So generally, as we're going, the fracture is actually going to get a little bit bigger after they've had it because it needs to be eaten up before it can be healed.
Got
Yeah.
it. And the recovery is a lot longer, but it also looks different, right? From like compared to an acute fracture that's a little bit more traumatic. How you actually recover is different. Like you don't always put a stress fracture in a cast, right?
Yeah, so the only stress fracture that you need to put in a cast is a navicular stress fracture, just because they have way better outcomes in terms of healing. They'll have way less non-union. I think 90% will unionize if you put them in a non-weight bearing cast. So that's probably the only one where you need to put them in a cast. But a lot of them you do need to put in a boot, which serves the purpose of the cast, or go on crutches. So I would be saying they are similar in that sense, because you do need to aggressively offload the bone. But they're very different in terms of how quickly you can reload them, and also the other things that you're trying to address and manage in terms of their actual general health and their training volume and principles.
Cool. Let's get into management a little bit later because, just what you're saying right now, I have tons of questions, but we'll try and put them on hold.
Yeah.
Let's talk about sort of sorry, go ahead.
I didn't actually answer your question. I didn't get to answer what a stress fracture is, because we were just talking about traumatic versus stress fracture. Stress fractures are actually bone stress injuries. That's a better way to describe them, because it's a continuum. We only start calling it a stress fracture when it shows up on a scan as a line, basically. But that doesn't just happen all at once. Generally, stress fractures are happening for weeks and weeks of time. And it's essentially just you're loading the bone. There's some micro damage and some micro trauma, little cracks, and then normally that'll go and get eaten up and healed and regenerated over weeks and weeks. But what happens is you have that loading, and then you have more loading, and then you have more loading. And there becomes this lag where the bone's not adapting quick enough. And as you go, bone's getting weaker and you're still loading it. We're starting to get the bone being severely overloaded and starting to break down. And this is when we have a stress reaction. So this can either present as just an ache because they're not that sore, or it can start to become very sharp and painful because the bone's actually becoming weaker and it's starting to bend and break down a lot quicker than we'd really like. So that may not show up on an MRI, because MRIs don't detect bone strength, but that stress reaction represents a significant reduction in the bone strength and tolerance, despite there not being a fracture line. So it's important to recognize that a stress reaction is basically an early stress fracture, and it can present very similarly and have similar timeframes as well.
Interesting. Okay. So that early sort of stress reaction that you're looking for, is that very different from when it's more identifiable, like there's a more identifiable fracture on MRI, or are the symptoms going to be very, very similar there?
It depends on the extent, and that's why it's a continuum, because a late stress reaction will be pretty much the same as a stress fracture in terms of presentation. But an earlier stress reaction that's just kind of starting will be much more of an ache that comes on after you've done training and it lasts for hours and days. It'll be much more of a little bit of kind of a hot feeling, or just a subtle general ache, versus a stress fracture will start to become a lot more sharp and focal and in a singular point.
Okay, got it. So if someone comes to you and they basically tell you the story where they say, like, the pain maybe used to be more widespread and last a while, but now it's becoming a little bit more pinpoint, is that raising your suspicion that it's sort of evolved into a stress fracture?
Yeah, that's always something that I'm going, okay, so it was just a bit of an ache and then you kept running and now your leg is incredibly sore. You can't, like, you're limping and you can't run. I'm like, okay, stress fracture. That's like straight away where my brain goes, especially because I see so many of them. I do have kind of a shifted, biased lens when I'm treating a lot of my patients, because I'm like, half of the patients I'm seeing at this point have stress fractures. So whenever someone walks in, I've always got like that heightened look at.
Yeah, and that's for anyone who maybe, like, you're a student or a layperson and you're not, in the clinic yet. I think that's pretty rare. Like, I do not see a lot of stress fractures at all. And I work in sports medicine, but it's just, I guess that's what happens when you're working with so many runners.
Yeah, runners have a very stupidly high risk of stress fractures for heaps of reasons. Number one, it's too easy to run. Like, people can run so much so easily and so quickly. So it's very quick and easy to cook yourself. And number two, runners and running itself don't build good bones. It's not something that's going to make you have the thickest, strongest bones. And if you're just going to go and do heaps of it, it's probably going to be slightly detrimental to your bone health if you're overdoing it.
What will help you build stronger bone?
Go to the gym. Just, pardon me, just get in the gym. Play some different sports. Lifting heavy weights has been shown consistently to increase bone mineral density. And in more recent research, we're starting to see that it actually increases the thickness of your bones. And that's probably even more important than the density. So chasing some heavy load in terms of weight, in terms of some harder plyometrics, incredibly important for building up your bone strength, but also doing non-repetitive tasks and sports. So playing basketball, playing soccer, and other change of direction sports is really, really good at increasing your bone mineral density, as well as the thickness of your bones. At least that's hypothesized, the thickness. I haven't seen any research on it. But if you play change of direction sports, you're at a massively reduced risk of having a stress injury because your bones are just stronger.
Yeah, I've heard that it's these more repetitive actions that aren't as good. Like running, it's not great for building bone. The theory that I've heard behind it is that it's sort of like your body just gets used to that stimulus after not too long, so then it stops being a good bone building stimulus. Would you agree
Yeah,
with that?
I think it is just because it's so repetitive. Like anything, the body gets desensitized to it. It's not going to respond the same way. And it's the same with gym. If you go to the gym and you just do the exact same weight and the exact same exercise and the exact same reps, like you're probably not going to make as many gains as if you vary the weight intensity and some of the exercises at least slightly. I think the difference with bone is it takes a lot of force and a lot of, or either a high rate of change in the force to stimulate bone growth and bone changes. And running just doesn't do that. It's kind of this awkward middle ground where you're not doing that much load and you're not doing that much of a change in intensity. And it's probably not enough to stimulate a lot of bone growth. So there is some studies out there that basically say that after about 40 to 60 of the same type of impact, the bone will become desensitized to it. That's like nothing. That's not even 100 meters for most runners.
Right. That's less than a minute of running, right?
Yeah, exactly. So if you're going and running for 2 hours, if you're going for a 20K run, most of that run, like almost all of it, is doing nothing to help your bone health, and it's probably just slowly loading up the bone. And if you've got any other troubles or you've increased the load too quickly, it might actually just be weakening the bone slightly.
Wow. So we spoke about a couple of risk factors already, and I want to sort of build this perception of a person that might be at a higher risk of developing a stress fracture. So far, we spoke about just maybe not those people that don't lift and who potentially have weaker bones. And we also spoke about how the fact that there's this repetitive loading with maybe not enough time to recover as a potential risk factor for stress fractures. So what else can sort of play a role in elevating someone's risk of developing a stress fracture? And also, if you want to dive into those two things that I just mentioned as well a little bit more, feel free.
Yeah, I think we'll probably just be a bit more general because there's a lot. There's a lot of things that contribute to bone health because it's essentially a marker of general health. If you've got anything like more significant wrong with your hormonal metabolic health, or even sometimes your mental health, it's going to play into how much you do and also how well your body can tolerate it. So whenever we're treating someone, we want to ask about their previous injuries, their previous activity, and their current activity. And then we want to be knowing what their previous health and physical and mental was in the past. So I would be always asking if someone's had a previous bone stress injury, because if you've had a bone stress injury, you're at a massively increased risk of another bone stress injury. So depending on the research,
even in another bone.
Yes. So it's actually more likely often that you'll get it on the other side because you'll have a reduction in bone strength on that side because you've generally stopped loading for a period of time on both sides, and then you'll load up the uninjured side more. It's similar to ACLs. Oftentimes people will actually tear their contralateral ACL, especially in younger people. It's actually more often that they'll tear the other side. You'll just load it more, and it's still not that much stronger than the other side because you've offloaded both of them. So that's only from one research paper that actually looked across both sides and other bones, most research only looks at just the site and if they recur at that site. So we do need more research in that space. I wouldn't be jumping to conclusions saying that everyone's going to get stress fractures on the other side. I would just be saying as well that, I kind of lost my thought a little bit. Yes, bone stress injuries are a massive risk. It's anywhere from 5 to 7 times the risk that you'll have another bone stress injury. So that's a huge change in the odds that they'll have them. And it's not just because they've had a bone stress injury. It's because they will have lost some bone mineral density afterwards with the offload, and also because that bone stress injury represents probably a number of other risk factors. So it's basically a collection of the risks in that situation. If they haven't addressed them, they're going to still be at a very, very high risk. If they have, and it's important that you ask and go through that with them, then they probably won't be at as high of a risk, which is great. So diving into what some of those other risk factors can be, unfortunately, one of them that's not modifiable is being a female. Being female has a very significant increase in risk, anywhere from 3 times the risk in military personnel to about 2.3 times the risk in females. Female runners, sorry. So that's unfortunate, and it represents probably a range of factors, be it less different hormones and different hormonal systems, different pressures in regards to weight and appearance that can play a role in their metabolic health and then later their hormonal health. And then also a reduced rate of sports participation in change of direction sports and in things like gym and lifting. Because those things are going to be protective, and there's probably some other factors as well that play into it that I'm not qualified to speak on. So it's unfortunate that females do bear the brunt of these bone stress injuries. And other things that can play a role will also be the activity that they're participating in. So sports that are repetitive, like running, are generally going to be much more likely to cause a bone stress injury. But also sports like gymnastics, where it's very repetitive, a little bit more high intensity, and there's a big emphasis on body composition. That's actually probably the sport that has the highest rate of bone stress injuries, despite being, quite variable and good for bone health, theoretically at least. Diving deeper, patients that have done change of direction sports, and if you ask them about it, they'll actually be at a much lower risk of having a stress fracture. So it's always important to be checking that, because it generally will reflect that they have denser bones, and that's a great thing for their rehab, because it means they'll be able to tolerate more quicker, or they might recover a bit quicker.
Wow, cool.
Going further, we need to talk about RED-S. Have you heard of RED-S, Noah?
Yes, of course.
Yes. So relative energy deficiency in sport is a very broad stroke term to define a huge range of issues. This is where we start thinking about metabolic, hormonal, and mental health around exercise. And when screening for patients with RED-S, that is our only role. We need to be screening so that we can refer on to people that are much more equipped to deal with it, be that a sports medicine doctor, a sports psychologist, a sports nutritionist, or in some cases, an endocrinologist. Really important that we can just flag those things. Obvious signs to look for.
How do you flag them?
Yeah, okay. The biggest things to look for, and these are the only questions you need to remember from this chat, is have you had a bone stress injury before? Right? If you've had multiple or any high-risk ones, you automatically need to be ticking that they probably have some bone health issues related to their metabolic or hormonal health. That's number one. Number two would be in females, you're looking for them to either have had a delay in their period when they were younger. So I think the cutoff is about older than 15 is considered a delay in menarche. That's going to be very impactful, because when you're younger, in your adolescence, that's going to be the time when you're developing most of your bone mineral density. And whilst you can develop it when you're older, how you develop it when you're younger sets the tone. So if you've had hormonal trouble based on your training or your lifestyle or your eating when you were younger, you're going to have massively reduced bone mineral density and massively reduced just health around the bones. So important to note that. Later on in life, if that person or that female has also then had trouble with their period where they've missed multiple in a year, I believe the cutoff is 5, I might be wrong about that, then that's a situation where their hormones have been disrupted, and those hormones are essentially what dictate how well the bone can recover. It's the thing controlling where things go and how well things heal. So that's in females. It's a lot easier, whilst it is uncomfortable and delicate to talk about those questions, it's a lot easier to bring out those issues because most females who are participating in activity will be tracking it, or at least they'll be aware of when these things started or when they've had irregularities. In males, it's a little bit more subtle and it's harder and generally a bit more, it's generally harder to talk about as well, because you need to be asking questions about whether they've had low testosterone on a blood test, which most people won't have had a blood test to check. So you need to actually be diving into, have you had a reduction in libido or sex drive? Have you lost morning erections during your training? Or have you actually had erectile dysfunction for the past few weeks or months around this injury? So those are the things that you need to be discussing to work out if this person actually has hormonal health issues.
Can you
To circle
quickly
back
touch
to,
on?
oh yeah,
Sorry, could we before we do circle back to whatever we were going to circle back to there?
yeah.
Can you touch on why someone might be experiencing these things, whether it's a reduced sex drive, or a reduction in the amount of periods that they have, or some irregularity in their menstrual cycle? Like, why is that?
Yeah, so it's probably better to rely on an endocrinologist for really, really thorough information on that, because I do feel like people try to explain it, and it's a very complicated system. But essentially, your hormonal processes require energy. So if you have a deficiency in energy, it's going to start to halt processes that it deems aren't as useful in order to preserve other parts of your body. So if you're not eating enough to function well, the first thing that's going to go is reproduction. So reproductive systems will start to settle down, and you'll stop having periods because your body doesn't have the energy to produce a baby, let alone produce a period. And then you'll start to have issues where, sorry, I've lost my train of thought. Yes, because you don't have enough food or you're exercising too much, you'll start to cut off these other processes. In the same respect, if you're not eating enough, you're not going to be able to build muscle, you're not going to be able to build bone, and your bone will start to be reabsorbed at a higher rate when you're not eating as well. So that's
I just wanted to make that one note there,
analysis.
just because. Yeah, I mean, and we don't need to, pretend like we're endocrines here, because we certainly are not. But yeah, I just wanted to make sure that was sort of the other thing that you're screening for as well. Like, we're not pros in diet or nutrition, but I mean, if someone says like I hardly eat, that should also be setting off your alarm bells there, right?
Yeah, definitely. And I would even be saying we need to be less specific or severe with that, because if we're training a lot, we don't need to not be eating. We just need to be missing some key things or just eating not enough for an extended period of time. So I would be just asking if someone excludes food. If someone excludes dairy or carbs or fats because they're following a very strict diet, then they are just going to have a hard time getting as much calories. And if they're training a lot, that's something that can play a factor. We also know that we want patients to have enough vitamin D and calcium, just because that relates strongly to bone health. So we do want to make sure that they're having either some dairy or a supplement for vitamin D and calcium. And then the other thing would be if someone's excluding like protein, or they're practicing a vegan or vegetarian-based diet, it's probably going to mean that they're not getting enough calories as well, just because it's harder to get those calories in. And they may not have as good muscular health because they don't have as much protein coming in. Muscle size and muscle strength is actually the predictor of bone health. The things that determine how much force goes through your bone and how much you have to respond to that force is your muscles. So that's the thing driving your strength. And if you don't have strong muscles, or you've had a muscle injury, then you're probably at a higher risk of a bone stress injury.
Cool. Interesting. Do you remember what you wanted to circle back to?
It was that. I just wanted to talk to you about like the fact that you screen for metabolic issues or reductions in nutritional intake.
Got it. I always find it so fascinating when we talk about these concepts and we just see, all these other risk factors that might be involved. And we're just reminded that the body really is an ecosystem. And although that we have these painful problems that maybe they just manifest in this one area, I think the lay person, or just maybe even us, we have this tendency sometimes to just really zoom in on that one area and think about how the problem is there. But there's often more of these global systemic health issues that can make it more likely to have a problem in maybe just one area.
Yeah, it's like if someone has massively reduced sleep. It's a huge risk factor for any injury, but we're not always asking those questions. When someone has a bone stress injury, it's really, really important that we address those issues, because if they have poor metabolic, hormonal, or just general bone health, there's a chance that they may not actually heal in the time that you're giving them in a boot or in crutches. Or when they start loading, they're not going to adapt well at all, and you're just going to end up right back in the same place. And for some of those stress fractures, if they're not healing, or if they're actually progressing and getting worse, you're looking at really, really long times off the sport and potentially not returning to sport. So incredibly important that we're making sure that we're not missing things, because those things are essential to manage in this situation.
And it sounds like maybe more than like most conditions, it's a multi-profession approach here, right? If someone has these certain health issues that aren't in place, again, we don't have the best training compared to other people, like a sports nutritionist, a sports psychologist, a sports med doctor, an endocrinologist that probably should be getting involved in that patient's care.
Yeah, super important that we know when to refer on. If you don't have in your network a good sports psychologist, an endocrinologist, or a sports dietitian, that's okay. You need to be letting the sports doctor organize those things and just prompting them that you think there are some issues around those factors. Just for everyone's reference, there's a really great tool that's come out this year, or the very end of last year, called by the International Olympic Committee. It's called the RED-S CAT-2, and it's got a range of factors, basically in order of the issues that they can cause and the issue of severity. And you can just go through those questions as best as you can to discuss with the patient. Some of them require blood tests or require a little bit more of a deeper medical history, but a lot of them you can just speak to the patient about.
Got it. RED-S CAT-2.
Yeah, it's great.
Cool. You touched on something there, that muscle mass is a really good proxy for bone health. I tend to think of the repetitive loading as potentially problematic because of maybe like compression forces. Like you're just putting a lot of force through these bones. But I think we also forget that muscles and tendons, they pull on bones, right?
Yeah.
So what's causing the stress fracture? What are these forces that cause it? Is it a mixture? Is it more one than the other?
So there is a very, very small role of the impact forces. But the reality is that if we just took the impact on its own, it's very, very small in comparison to the bone forces that the bone will experience, because the muscles impart much, much, much more force. The bone isn't able to do any work. So if I dropped you off of a box, Noah, and it was just your skeleton, you would just collapse.
Mm-hmm.
And there wouldn't be that much force actually through the bones, because it's an inactive structure. If we talk about if I dropped you off the box and made you land and absorb it, then the things that are resisting that absorption and resisting you from just collapsing are actually your muscles. Now, all of us, or most of us, will have heard some of the Dawn research where the calf is taking anywhere from 6 to 8.5 times your body weight just in your soleus muscle, and your gastrocs will do 2 to 3.5 times your body weight. That's huge. The max that people will put into the ground when they're jogging along will be about 2 to 3 times their body weight. We're talking about almost like 11 or 12 just from your calf muscles alone. So that force pulling on the bones is what is going to drive bone loading. So when we've done studies on running and on jumping, there's this tiny little blip in bone loading as you're running along. And then as your muscles absorb the force and then give you back energy to then not only absorb, but go, there's this huge spike in bone loading that dwarfs the ground reaction force. When we've done other studies, the ground reaction force might spike at these random points, but the actual bone loading is happening at completely different points. So it's important to recognize that impacts play a role, and particularly in like a calcaneal stress fracture where there's no muscles to absorb impact. But for most other injuries, it's primarily muscle force driven that we're having these stress fractures develop. To give you an analogy, this is just how I like to explain it to patients. Imagine your bone is the wooden part of a bow, and then the muscles are a bowstring. When our muscles are contracting, they're going to pull on that bowstring. They're going to be pulling and bending that wooden part in that bone. Now, it's very, very subtle, that bit of bending, but it's enough to impart quite significant forces at specific parts of the bone. So we'll have compression on one side. Yeah, we'll have compression on one side, and we'll actually have tension and opening at the other side. Now, bone is generally quite good at absorbing compression. it's really terrible at absorbing tensile loads.
Mm. Okay, so it's more on that edge of the bow that's further away from you that you might be a little bit more worried about.
Yeah. Just the forces vary a lot based on what you're doing and where the bone is. But essentially,
Yeah.
anytime you've got a tension based stress fracture or it's in a tension based location, just a stress reaction, you're much, much, much more worried about that patient because the bone can't really heal that well when it's being pulled apart. So if you've already got a fracture and the loading in the bone and the muscle forces are going to pull it apart, it's essentially like micro displacing it, as well as the fact
Mm.
that like bone doesn't really have a way to adapt to tensile stresses very well. So we've got a situation where bone's being pulled apart, it can't heal well, and then also it doesn't know how to heal even if it could. So you're in a situation where those patients generally are going to have much slower rehabs, be much more aggressively offloaded, and even still can have much worse outcomes.
So what are those areas where that tends to occur?
So
In runners, we'll say.
let's talk about everyone because like it
All
happens
right.
across all different sports. The worst stress fractures in terms of like order that we have good research about would be femoral neck tension sided stress fractures. That's basically just along your femoral neck on the top or on the outside of it. Basically, it's just being bent by the muscle forces, and when you're landing and impacting, it's being bent, and the top side is opening up. The second worst would be the anterior tibial cortex stress fractures, which are very, very rare, and we don't have heaps of research. And then following that, it would be navicular stress fractures, just because they take very awkward forces and it's very, very high force. The following that would be the fifth metatarsal, and then a range of stress fractures that we just don't really have good evidence about would be the actual patella itself can have a stress fracture, either because the patient has a small bit of bone that's separate to the patella and they'll have awkward forces interplaying between them, or because the tendons, your quad and your patella tendon, will impart awkward stresses that literally just pull the bone apart. We also have sesamoid stress fractures in the big toe. Those are really problematic. Just because they're so small, it's hard to operate on them. They don't have good blood supply, and the big toe imparts heaps of forces on them, tensile forces. And there's another few. Oh yes, any subchondral stress fracture is a lot more troublesome because it's going to be of a softer, spongier bone that takes longer to heal, and also it's going to disrupt the joint if there's any kind of basically compression and breakdown where it's breaking underneath the chondral surface. Not to mention, it's really hard to offload a chondral surface for a long period of time. Like it's hard to get off your leg for 6 weeks, 12 weeks. So femoral head stress fractures or femoral condyle or tibial plateau stress fractures, those are troublesome, as well as talar dome stress fractures. Those are all going to take a long, long, long time, and we don't have a lot of research, so we need to be involving sports medicine physicians and screening for RED-S aggressively.
Hey, physios. I know that we all know how expensive continuing education courses can be. What if you had the chance to learn from some of the brightest minds in the industry from the comfort of your own home, all at the fraction of the cost of those weekend courses? This is where Masterclass by Physio Network comes in. Imagine having front row access to the world's leading experts breaking down complex topics into digestible module-based video courses. It's basically like Netflix for physios, and it gives you the option to learn about a ton of different topics. If you're interested in a particular area, the chances are that Physio Network already has a masterclass on it, or they're working on one right now. Masterclass is your ticket to staying relevant, informed, and delivering the best care possible to your patients. Click the link in the show notes and use the discount code NOAH10 at checkout to get an exclusive 10% off on Masterclass. Don't miss this opportunity to elevate your expertise. If you're still unsure, test it out with a 7-day free trial. You're going to love it. So are you classifying them as the worst just because they could take so long to heal? Or are there other sort of things that you're concerned about if these things progress?
So just to, like, we do have a big systematic review on the actual complications related to femoral neck and anterior tibial stress fractures, as well as the return to sport times. The complication rate for femoral neck and anterior tibias is like 40%. So 40% of them will
Wow.
go on to progress, require surgery, or have other complications in regards to like other stress fractures. So they're really, really bad. In terms of failure to return to sport, it can be anywhere from 10 to 50% for an anterior tibia stress fracture. Like 50% of people may not get back to sport in some studies. It's lower now when we see operations performed where they put a pin or like a rope to hold the fracture together. It's down to like 10%, which is really good. But femoral neck stress fractures as well, I believe it's around 40% won't return to active duty in the military. And a lot of them won't return to running or other activities as well. So really dangerous just in terms of return to sport and in regards to complications. Does that answer your question?
It does. Yeah. With the femoral neck, are you worried about any like dissection of any arteries there as well?
I think I'm not aware of that in just stress fractures. When you have a stress fracture that completes and it displaces, yes, you're super worried
Right.
about vascular and neurovascular issues. So that's a situation where, and this is actually why tensions are so considered so high risk. They did a study on 400 military personnel trying to identify who does the best and what things predict how people go. They didn't even find a single tension-sided stress fracture. And my perspective, and this is just an assumption, is that they just propagate immediately. Like as soon as you start getting a tension-sided stress fracture, it's probably just going to really quickly progress to a full, complete fracture. And that's why they didn't see it. So yeah, it's pretty scary to think that as soon as you start getting a femoral neck stress fracture on the tension side, that it could potentially just be propagating really quickly.
Yeah, it is scary. Let's say it doesn't, right? And you catch it early. There still seems to be this massive issue of people returning to the things that they love, whether it's sport or running. Like you would think that with many, many months of healing, that these people could eventually return to what they want to do. Why is it that so many people struggle?
Yeah, so I think it's for a very big range of issues. The number one being that, again, they need to have those other factors addressed. If we haven't
Mm.
improved their metabolic or hormonal health, their bones just won't heal the same, and it's going to take a long time. The other issue is actually the offloading, because assuming we've offloaded them and we've let them heal, that offloading generally needs to be prolonged enough that will have a reduction in bone strength. And if we've actually been non-weight bearing, a lot of patients can get like osteopenic and be at a much higher risk of bone stress injuries. So
Mm.
that actually tends to happen at 6 to 12 weeks, which generally most people will be out of a boot at 6 weeks. And then their bone health will actually be worse 6 weeks later, right when they start generally running. So we need to be managing them to have really good bone strength before they start the activity that causes the problem. And part of it is just a mismatch of goals and the reality of the healing. We do tend to in physio get stuck in our ways around practice, like time frames. Everyone loves time frames, but if we're being honest, it's probably better, particularly in this case, to either be loading them a little bit earlier so that they can get stronger bones, or if we have to offload them for a long period of time, we really just have to give them a lot more time to develop their bone strength, because about a third of people won't even have the same bone strength at 12 months. So they'll have reduced bone strength for 12 months after they've had this injury. And if you're expecting to get back to the same level in 12 months and your bones aren't as strong, you're going to have a really tough time, especially avoiding a re-injury related to the bones. So from my perspective, the things that would reduce this problem is, when we can, loading them earlier, and be that on the uninjured side, which we should be aggressively loading as soon as possible with heavy weights and plyometrics and other things like that. And then for our lower risk stress fractures that can tolerate it and are safe to do so in low risk patients, we should be trying to load them earlier than we probably normally think we should. So for tibial and metatarsal low risk bone stress injuries, there's a paper that's come out by Rich Willey and fellow name, his last name's Edwards. I can't remember the third author. I always forget the third author. I feel bad. But it's basically just highlighting that we can do pain-free loading in tibial and metatarsal bone stress injuries that are low risk. So as long as there's no pain, if someone's walking
At what time point?
at any time point. So I've had
Wow.
patients that have had a stress fracture and MRI, and then they're pain-free walking 2-3 weeks after they've had the stress fracture. And in tibial and metatarsal bone stress injuries, it's probably okay that they start walking around for short distances at that point. I wouldn't be smashing them. Like I wouldn't say, oh, you don't have pain hopping, I'm going to start hopping. But I would be saying, like, let's start building towards hopping and let's go and build based off your symptoms. So in tibial and metatarsal bone stress injuries, that are by far the most common, I would be saying, yeah, if they're not sore and they're low risk and they don't have any risk factors, do anything that doesn't really hurt. Okay? You can follow that principle to start loading them sooner so that they don't lose heaps of bone strength everywhere or in that area. That's going to be really, really helpful. On the flip side, though, for other bone stress injuries in spongy bone or trabecular bone, it takes a lot longer. They don't have the same pain systems. It's hard to monitor them, and it's also just going to take longer. That's a situation where, along with high-risk stress fractures, you frankly just need to wait longer and spend more time building their bone with productive things like weight-bearing exercises that are heavy and loaded, and then plyometric exercises. Those things are what's going to get you back with stronger bones and ultimately at a much lower risk of having this issue. So I'm in favor of delaying return to run, or at very least loading them as early as possible to improve their bone strength.
Got it. Yeah, when you say high risk here, I just want to make sure that we have a good definition of that. It basically means that it might take longer to heal and that there's a higher risk for complications. Would that be correct, or am I missing the point there?
So I would probably just say any stress fracture that's at a tension site is high risk. Any fracture that has poor blood supply is at a high risk. And then generally, spongy bone or trabecular bone stress injuries are at high risk because, like I said, they just take a bit longer to heal.
Got it.
Yeah. The probable definition that you'll hear from other surgeons and sports medicine doctors is that they'll have non-union, so they actually just won't heal. Those are the ones that are considered high risk. So that's like your anterior tibias, your medial malleoli, your naviculars, and your fifth mets. Like those are the ones that just won't heal. So that's probably one classification. I like to take multiple things and then also look at the research and data that we have.
Got it. It seems like it's so much easier to lose bone health than it is to gain it, right? Would you say that's the case?
Yeah, it's the same with muscle mass. Like you can lose muscle mass really quickly with bed rest or immobilization, or when you have an ACL injury. Like it'll absolutely fall off a cliff, and it will take you months and months to build it up. And that's why it is important when we can to start like keeping them weight bearing or start loading them. The time frame I think it's probably not as long as we think, because you can improve bone mineral density by 1 to 2% with about 6 to 8 weeks of loading, and you can improve thickness as well by about 0.5 to 1% in about 6 to 12 weeks. So it's not super slow, but God, it is slow. So we just need to bear that in mind, because I haven't even mentioned how long it takes for bone to actually heal and remineralize. Like it takes about a year or 6 months to 2 years for the bone to reach its normal strength after you've had some micro damage to it.
From a healing standpoint.
Just from a healing standpoint, it's like the ligaments in the ACL. I know I'm just talking ACL because I know you love ACL, but religamentization takes years, right? And at like 6 to 12 weeks, generally for ACL as well, they're just way weaker because the graft is being basically vascularized and broken down. It's very similar with bones. It does take a long time. You need to let it take its time and make sure that there's nothing in the way of them healing.
And you won't know for a while, when it's reached its peak of that sort of healthy healing, right? When it's reached its full strength again. Like with the ACL, people are not symptomatic well before they get to that point where the graft is fully matured. And it's the same with bone, correct?
Yeah. So we do try to use things like DEXAs, which is just like repeat X-ray that measures the density of your bone. Some you'll get repeat MRIs to make sure it's healed, and then others you can just use repeat X-rays to make sure it's healed. But it's the same with like an MRI for an ACL. An MRI doesn't tell you how strong the ACL is, because it might look thick and strong, but it might not actually have that much basically tensile properties. And it's the same with bone. We're not measuring the strength of the bone by doing that. And by 6, 12, 18 weeks, most patients won't have any pain with loading, just because there's no more blood or swelling or sensitization of the bone. So that doesn't mean their bone health is back to normal. Like I said, some of these patients are taking 3, 6, 12 months just to get back to their normal bone mineral density. And just saying, oh, it doesn't hurt, isn't good enough to me in a lot of cases, other than maybe your tibial and metatarsal bone stress injuries, because they specifically are long bones, and in the cortical part, they'll actually have a fracture callus form in 1 to 2 to 3 weeks. And that fracture callus massively improves the strength. So they've done studies on rats where they've basically just given them a stress fracture in their arm, and the bone's tensile and compressive strength will be back to 80 to 110% of its strength within a week or two.
Oh, wow.
Yeah. So for those specific sites, you don't actually need complete healing of the injured bone. Other parts of the bone will just get really, really strong and protect you. But for other fractures like high risk and like the trabecular bone, it doesn't work the same. It doesn't restore the strength, or it doesn't heal as quickly. And that's a situation where you really do just have to wait for the injured bone to heal.
So it sounds like then the decision to return to sport would be a clinical one. And yes, of course, if the imaging showed that the bone has not healed yet, you're not going to say, "Oh yeah, go for it, go run."
Yeah.
But so what goes into your clinical decision making when you are clearing someone to get back to running or to return to sport? How do you make that decision?
Yeah. So number one, they have to have no pain with activity, be that bone pain with activity, be that at night, be that just a little bit of an ache, be that during, and specifically during the exercises. That's the very first thing. And they had to have had no pain with that loading for like weeks to me. The second thing would be they need to have gone through a graded rehab program that includes heavy strength training and plyometrics. And those plyometrics should gradually be reaching the level and the requirements of the sport. And that needs to have been going on for 6 to 8 weeks for any of the higher grade bone stress injuries, just so that I know that the bone's going to tolerate it. And then probably just on top of that, considering the patient's risk factors, if they have metabolic, previous bone stress injuries, or hormonal health issues, I will only be progressing them every 5 to 7 days. So I won't be going like, oh, lift more every 3 days like I would with a low risk stress fracture in a healthy patient. I'll be making them basically go very, very slow. And just based on how long it takes to get through those progressions will determine how they get back. Because after that period of time, I can't rely on their symptoms as well. And I also can't rely that their bone has regained the strength as quickly as I would like. So factoring that in, they just need to go through a gradual return to that activity. And once they're hopping or jumping pain-free, I would be implementing some running. And I would be gradually increasing their volume first, because volume is a lot more easily tolerated than intensity when you have a weakened bone. So push up their volume for their runs, keep their frequency low, basically only have them running every 2 to 3 days, and then really gradually build that up and layer in some hills, some speed later on. Some people will say that you shouldn't do speed work for 6 months after a bone stress injury, and I think there's some truth to that, but I think if you're going to add in speed work, you can make it work a lot sooner for patients that are healthy and have good bones. And essentially the way that you would add speed earlier is by reducing their volume a lot, because small increases in intensity massively reduce the rates of repetitive cycles that they can do. So there's a stat basically out there from a paper on bone strength and response to loading. About a 10% increase in intensity will reduce the cycles that you can do by about 50%. So small increases in pace or speed or intensity or weight really reduces how much you can do.
I see. Yeah, I've heard Rich really talk about that, and it was sort of just what you were saying about opting to progress volume before you opt to progress intensity, right? I guess you could be a little bit more, like a little more. I don't want to use the word aggressive here because this isn't the type of population that you want to be aggressive with, but you could be, I guess, a little more liberal with progressing volume than intensity, right?
Yeah, yeah. And I think like how aggressive you are just depends on their risk factors as well. Like I said, I have patients that have great bone health. They've played change of direction sports. They've never had a bone stress injury. They've cleared all of the other markers. They have no risk factors. And we go through a screening where we make sure that they get really, really strong and they don't have any symptoms. Those patients, I'm pretty happy to push quicker. Like I've got patients that have had a really high grade stress fracture in their shin who will get back to running 90, 100 Ks a week in like 5 months,
Wow.
which is like massive. So we
Yeah.
use strategies to monitor them to make sure that they're not going to start to set back. But realistically, if you check for everything and you have the information behind you, you can make informed decisions. There's obviously risk with that, which you explain to the patient, and you discuss with them where their goals align. But you can be quite confident if you're monitoring and managing them well.
Mm-hmm. Awesome. You've done such an amazing job at breaking all of this down. And I think it would be really cool to finish off with just trying to wrap up and basically give someone like a case study, from sort of like start to finish, how like first off the diagnosis, then we get into the treatment and then sort of the return to sport decision making. And I don't know if you're open to it, but as you mentioned at the start of the podcast, you had your own stress fracture that you dealt with. Would you be
Yes.
willing to just talk about your story, sort of like how it came about, how it was diagnosed, and how you treated it?
Yeah, so I actually had an anterior tibial bone stress injury, a grade 3 anterior tibial bone stress injury 5 months ago now. So I dislocated my shoulder 2 weeks or 2 months beforehand. I can't remember the exact time frame.
Man.
It was 6 weeks. No, 6 weeks beforehand. And because I couldn't train upper body, and I'm someone who like needs to exercise and do things, which is something you'll see in a lot of patients with stress fractures, I started running and jumping heaps as soon as my shoulder started tolerating it. So I was running, I think 4 times a week, doing 5 to 10 Ks. Like I'm not that good of a runner in myself. And then on off days, I was doing heavy strength training, but also far too many plyometrics. So I was doing anywhere from like 20 to 30 really high intensity impacts to like 100 lower intensity impacts. And then in the clinic, I do heaps of sports testing. So I would be demonstrating plyometrics to patients pretty much every day, getting like a few extra impacts. So that was a really, really quick and easy way for me to give myself a bone stress injury. It started very, very subtly on a 10K run that I was doing, and it was like a slow, easy one. I just started getting a little bit of an ache, and I knew what was happening. I felt like I had to exercise at the time, so I made some very rash decisions and basically kept running on it. I paid for it a little bit because it was a tiny bit sore that afternoon, and it was a bit sore that night, but it was very mild. And I just told myself, like, look, if it increases even by 1 or 2 out of 10, I'm going to stop. So that's what I gave myself to control it, which is never a good idea. Like, it's a really bad idea. If you've got bone pain and you're running and loading on it, they can turn around really quickly. Because pretty much the next day when I went to do some pogo hops, some like skipping on the spot, I think I did like 8 seconds of it, and then I felt like an incredibly sharp pain. It just went from like not that sore to very, very sore, and I just had to stop doing that, limp back upstairs. I physically like couldn't hop, I couldn't jump, and then that night my legs swelled up down into my shin and foot. I had like this hot sensation everywhere, this ache, and then every time I would like land awkwardly, I would just get this super sharp pain. So being the smart-ass physio that I was like poking it, checking it, trying to work out where the pain was, because it was a bit more general, and I was very tender along like the medial surface. There was one spot where I was like, ow, that really hurts. And I was like, oh crap, I've given myself a stress fracture. And me having read the research, I was like, oh, I can keep going as long as it doesn't hurt. So instead of putting myself in a boot like I should have, I just limped around, which was silly. No, actually it wasn't silly. It was actually a good idea. It's just the problem became when I came into the clinic, I would forget that I had a stress injury in my shin, and I would demonstrate exercises to patients. So
Oh
like 2 days
man.
later, I just demonstrated a jump, and my shin lit up, and I realized the pain was actually in the front of my shin. Like it really, really hurt in the front of my shin to palpate. And when I did the jump, I went, oh crap, like this is bad. So I spoke to some colleagues, and we basically just got me an MRI immediately, and got an X-ray as well. The X-ray showed a strange line that was unrelated, and I got confused by it. I was like, why is that there? It looks like I've broken my whole shin in half, but it was just a growth-related line. And then there was actually just a tiny bump on the front of my shin as well, which was like immediately put me on crutches when the X-ray results came back. When I looked at the MRI, I could see some subtle changes in the front of my shin, basically just some swelling and edema. So I basically was like, well, shit, I've cooked this. That's bad. I kept myself on the crutches for a few days until I saw a sports doctor. The sports doctor went through everything with me. I have very high bone mineral density from playing sport and doing gym all of the time. I have no metabolic risk factors. I only had the risk factor of being very committed to exercise and having like a compulsion to do it. So that's like the only real risk factor that I had. And I just basically had to manage that. But he was happy for me to walk around in a boot for 6 weeks. And then we had a repeat MRI to confirm healing. I was lucky because the MRI did show some changes, as did the CT. Oftentimes with these anterior tibial cortex injuries, the symptoms aren't as pronounced as mine, and they come on a lot slower. And because they come on so slowly and there's not good blood supply to that area, they won't show up on MRI. And you have to get a CT or an X-ray to find them. So I was very lucky that the MRI found it and then also showed that it was healing. And based off all of those things, I've been able to progress quite quickly, getting back to lifting and jumping. Unfortunately, I got back to running very slowly, and it wasn't slowly enough, and my shin got sore again. So I went back in a boot for 2 weeks to let it settle. The very good thing about rehab when you do get back to running and loading, as soon as you start to feel symptoms, it's a sign to stop, but it's not a sign that you've re-fractured the bone. Generally you'll have gone so slowly and so gradually that you won't have had enough time to accumulate damage, and you won't have had enough load to accumulate damage to break the bone. So when I did have that bit of pain, I went in the boot for 2 weeks, but for my low risk patients, I'll actually have them only just offload for 3 to 5 days. Which is really helpful, and it's really reassuring to them to know that. So I'd always be emphasizing that you're not going to break your bone in 4 weeks of really low intensity training that only increases gradually. So if you do get symptoms, we just need to dial back for a moment. So I had a flare up and I've had to come back. But the whole time I've been trying to do weight bearing exercises. So in the boot from week 4, I was actually doing squats, I was doing lunges, I was doing deadlifts, which is quite awkward. I appreciate my patients' struggles now. And I was doing leg extensions with the roller above my fracture so that it didn't bend the bone, as well as like just deadlifts and things like that, which has been really fun. I only started doing running after I'd done 2 weeks of hopping, and I built up to hopping from basically bodyweight single leg calf raises to heavier calf raises with some basically rapid pulse building into some single leg pogos. So I very, very gradually built up through it. I very, very gradually returned to running. But unfortunately, these stress fractures, despite me not having any real big risk factors, they take a long time. And I'm 5 months out, and I've had to basically dial back for a month and a half now. And I'm just not going to run for another month probably while I build up my bone strength and tolerance, which is super frustrating. Like I'm losing my mind quite a bit trying to manage it. But it's easier when I see patients and we have the conversations, and you just you can recontextualize it and separate yourself to manage the injury a little bit more gradually. So to summarize that, it happened gradually until it didn't. You shouldn't run when there's any bone pain. I was very tender over the medial surface, but also the anterior surface, and I couldn't hop. That's like a huge sign that you've got bone stress injury. If you also have pain on just impact, so I stomped my heel one time and I had like a super sharp pain shoot up through my shin, that's not using any muscles, that's only loading the bone and not that much, and it really cooked my shin. That's another test that I've actually started to use since that to check for bone stress injuries in the tibia, in the shin, in the metatarsals. And when I did think I had a stress fracture, I got an X-ray immediately, and when I thought it was high risk, I went on crutches and got an MRI, as well as going to see a sports doctor to manage everything. So, in the return to sport, super gradual, and it still didn't go that well, so I'm a bit frustrated about it.
Yeah. Well, I thank you for sharing all of that. I can imagine how frustrating it must have been for you. So thanks for sharing your story, because I'm sure a lot of people, including myself, will get some value out of it just from a learning standpoint.
Yeah, 100%. I've already done another podcast where I just go through that case study with some running physios and some running coaches down here called Stronger Stride Physio. So we go into like the nitty gritty of it if people want to. Sorry to plug another podcast on your podcast, but just what I
That's okay. I mean, we're at the end now, so if you guys haven't gotten your podcast fix, you can go check out that one. If you want, you can plug it again, and also just plug anything else that you want. Where can people find you?
Yeah, so the other podcast that I did was Stronger Stride podcast with Sophie and Lydia. Excellent runners. Liz is a physio I work with. She's a gun. And we just chatted about the case. It was really good. If you want to follow me on socials, I'm on Instagram as the Stress Fracture Physio. Just Stress Fracture Physio, not the. I'll be posting heaps of stuff about stress fractures for years and years now. So if you want to jump in, exclusive content there just around stressies. And then I'm on Instagram as well as Beau Science 101 for more general physio content around ACL, sports injuries, testing, just different things about physio.
Awesome. Beau, thank you. That was a masterclass.
Easy, mate. No worries. I loved it. You have a good one. Yeah, no?
Cool. Yeah, you too.
See you, mate.
Thank you once again for listening to the podcast. If you enjoyed it, please consider leaving a review. If you would like to follow me on social media, you can follow me at noahmandel.physio on Instagram and TikTok. Have a wonderful day, and remember to keep moving forward.